All right. Well, welcome everybody to this virtual learning collaborative focused on improved care for developmental disabilities and dysmorphic features, brought to you by the Midwest Genetics Network at the Michigan Public Health Institute in partnership with the Minnesota chapter of the American Academy of Pediatrics and the Minnesota Medical Association. The Midwest Genetics Network is a seven-state network funded by the Health Resources and Services Administration, which some of you may know as HRSA. We focus on access to genetic services for medically underserved individuals. This continuing education and quality improvement project is one of many resources developed by the Midwest Genetics Network, Stakeholder Education and Engagement Work Group, and that work group happens to be co-chaired by today's speaker, pardon me. Sorry about that. One of the disadvantages of working from home, we get to have unexpected interruptions. So there are currently 48 providers from 10 states participating in this project. The providers come from practices in urban, suburban, and rural locations, and from a variety of settings, with a majority of you, about nearly 40 of you, from independent medical groups, the medical group component of integrated healthcare systems, and and hospital-based clinics. Now, after each presentation in our series, there are 4, by the way, there will be an opportunity to ask questions and share experiences related to the project. I would really like to encourage all of you to take advantage of the diverse set of experiences that are represented in this cohort by actively participating in those discussions. So at this time, I would just like to take a moment to recognize the many partners that helped develop this project, including our family representatives from the network, primary care providers, geneticists, genetic counselors, public health professionals, patient advocates, and many others from both within our 7-state region and beyond our region that were instrumental in putting this together. Some of which are actually on the call today and probably will participate with us in the Q&A session at the end. So thank you all for your participation in making this project possible. And then finally, I'd like to introduce the MGN, or Midwest Genetics Network staff that is here at MPHI. So I'm Matt Edick. I'm the director of the Center for Strategic Health Partnerships at Michigan Public Health Institute, and I'm also the director of the Midwest Genetics Network. Also from MPHI on the call with us, we have Danielle Baumgartner. She's a senior project coordinator for MGN Stakeholder Education and Engagement Work Group, and she will be your main point of contact throughout this project. Katie Justice is also on with us. I think some of you have gotten to speak with her recently. Katie is a research associate for MGN, and she supports the network's program evaluation, and also was responsible for developing the data aggregation system that all of you guys will use, you already have used to register and will use to enter your audit data. I happen to amicably call that the Justice 2020, but I'm not sure that it has caught on yet. We'll see how that goes by the end of the project. So Danielle, do you have any last housekeeping items before I introduce our speaker today?
No, I would just add that you can add any comments or questions to the chat feature, and at the end we will go through those. If we could just hold off on any questions that we're asking until the end, that would be great. And that's it, Matt.
Okay, thanks. So it's my great pleasure today then to introduce our speaker, Dr. Miriam Behar. Dr. Behar is an associate professor of pediatrics clinical track at the University of Kentucky in Lexington, Kentucky. She completed medical school and a pediatric residency at Johns Hopkins, and she practiced in private pediatric clinics in Oklahoma, Texas, Missouri, and Michigan before joining the faculty at University of Kentucky, where she enjoys teaching of residents and medical students. I also like to mention when I introduced Dr. Behar that she was my children's pediatrician when she practiced in Michigan. And my youngest child has Down syndrome and had many significant medical complications early in life. And my family struggled to manage care recommendations from numerous specialists, I don't even know how many anymore, who often were not communicating with one another. And Dr. Behar was invaluable to my family in navigating this, and without her commitment to providing high quality care for patient and family alike, I'm not so certain my son or even my family would have survived those first couple years of his life. So it's really a great pleasure for me to get to work with her. Dr. Behar has been a member of the Midwest Genetics Network since in 2017, and she's currently a member of our network's advisory board. I mentioned already she also co-chaired the network stakeholder education and engagement work group that developed this particular MOC and continuing medical education project that you're participating in currently. So without further ado, I would like to turn this over to Dr. Behar. Thank you.
Thank you. Thanks so much. That was a sweet introduction. I wasn't expecting that. And it's my privilege to be part of this project. I'm really excited to be the first presentation to launch this MOC4 project, and thank you all for being here. So next slide, Danielle. So I don't have any conflicts of interest to disclose. Next. So we'll just go over educational objectives, and first and foremost is to discuss the importance of developmental screening at well-child visits, and I kind of use Bright Futures as a framework for this talk. Some of you may be familiar with it, but I'll talk about it in a minute. This is a document that comes out of the American Academy of Pediatrics, and I've been a primary care pediatrician for 37 years, and I really feel that developmental screening, along with vaccinating children, is one of the most important parts of my job at well-child visits. We're going to review some of the standardized screening tools for both developmental delay and autism. And then just briefly at the end, I have a reference that kind of reviews key milestones from 10 to 35 months. Next slide. So this is Bright Futures. Just a lot of you are probably aware of it, but if you're not, I highly recommend incorporating this into your practice. It originally, many years ago, it was called Guidelines for Health Supervisions, but it became Bright Futures sometime in the last 10 or 15 years, and it's now in its 4th edition from the American Academy of Pediatrics. And I use this actually as a reference for teaching residents and medical students. I recommend that they all purchase it. And what it does is it provides a framework for health supervision starting at birth and progressing all the way through late adolescence. And it's built around 12 what they call health promotion themes, and it recommends that each of these themes be incorporated into health supervision visits. Next slide. So I'm just listing the 12 health promotion themes here just to give you a sense of the scope of what we're supposed to be incorporating into our well-child visits. And obviously not all of these themes will be emphasized at a visit depending on the age of the child, but most are going to have some relevance. And the first two, which talks about families and communities and family support, actually touches on social determinants of health, which we've all become much more aware of, especially in this era. So this talk is going to focus on theme number 4, which is promoting healthy development. Next. So we're going to kind of just launch into kind of the basics of developmental screening and why we do it. Next slide. So the reasons for doing developmental screening at well-child visits are two-pronged. First of all, children with delays who are identified early can be referred for early intervention services, and I'm going to talk more about early intervention later on. And we're talking about services such as speech and occupational and physical therapy, which will allow them to progress to their full potential. And the second reason is that children with delays may have an underlying diagnosis, such as a genetic variation or syndrome, and families really deserve to have an explanation for their child's delayed development if there is one. So depending on what you find during your screening, there may be other referrals that you need to make to subspecialists and other ancillary services to refer their child for diagnosis and treatment, such as genetics or neurology or developmental pediatrics, etc. Next slide. So I wanted just to give you an idea of the potential diagnostic yield of doing genetic testing in children. Again, our focus with this work group is making access to genetic services. So just what the yield is of doing genetic testing in children who have been determined by their primary care provider to have developmental delay. And I'll just kind of run through these numbers. So 15 to 20% of children might have abnormalities on chromosomal microarray testing. 1 to 5% may have abnormalities on Fragile X testing. 1 to 5% might have an identifiable metabolic disorder. And on whole exome sequencing, which is a newer, more comprehensive test, you might have 36% overall diagnostic yield for individuals with developmental delay. So and these numbers are rough. Some of them are pulled from a 2014 policy statement from the American Academy of Pediatrics on evaluating a child with developmental delay, and some others were supplied by the speaker for some of our future presentations in this series about the genetics visit and genetic testing. And just to give you a little bit of a kind of a heads up and a plug for further talks in our series. Some of those talks will focus on the different genetic testing modalities and really dive deeply into what they do and what they look for. I mentioned metabolic disorders, but we're not going to be talking about specific testing for metabolic disorders in this series, but I did want to mention it because it may be part of the recommended workup for a child with developmental delay. So currently, the chromosomal microarray and the Fragile X testing are considered first-tier tests for developmental delay and or autism. And again, in a future presentation, you'll hear that whole exome sequencing may at some point become a first-tier test as well. So go on, next slide. So I just wanted to review just some terminology that we're going to be using during this talk. So I use the term developmental delay mainly to refer to kids under 5 years. After 5, you can start doing standardized testing for, to actually measure intelligence, and then we start using terms like intellectual disability or cognitive disability. But basically, what we're talking about when we're talking about developmental delay is delay in attainment of expected developmental milestones at a certain age. The link that I provide below is from an older statement from the American Academy of Pediatrics from 2006, and it talks also about the evaluation of children with developmental delays. This report really emphasizes the importance of children being evaluated by an experienced provider, so a pediatrician or another primary care provider, but evaluating using norm-referenced age-appropriate standardized measures. So we're going to talk about some of these tools in a little bit. And this is what we want to use to monitor a child's development and to determine whether the child is meeting expected milestones. Next slide. So this was a study that I found when I was researching this talk. This was fairly recent, from April of 2020 in Pediatrics by Lipkin et al. From Boston Children's Hospital. And they looked at self-reported rates of developmental screening by pediatricians. This came actually from the American Academy of Pediatrics, and they looked at surveys that were conducted in 2002, 2009, and 2016. And as you can see, during this time span, there was improvement in use of developmental screening tools from 21% to 63%. And they also showed that, that referrals to early intervention services across this time period improved from 41% to 59%. But note that as of 2016, a full third of pediatricians are still not using formal screening to detect children with developmental delays. Now, there's a commentary in this article that was interesting. It kind of cuts a little bit of slack, you know, for pediatricians that choose not to use formal tools. You know, that especially, you know, some of us that trained a long time ago and aren't used to using these tools. So we kind of defer to our clinical judgment. The study recognizes, the authors of the study recognizes that this is a complex issue and that it's going to differ basically depending on the practitioner and their patient population. But I think the overall thrust is really to encourage use of formal screening tools and not just relying on your quote clinical judgment. Next slide. So I wanted just to talk a little bit more about, you know, how we want to conduct this screening during the well-child visit. We really view the well-child visit as a collaboration between the caregiver and the healthcare provider. And I can't stress enough the importance of paying attention to what the caregiver tells you. They're the ones that see the child every day. So any concerns that they have, you really need to take seriously. Of course, you're going to make your own accurate and informed observations of the child, but you're only seeing the child for a small snatch of time in the office. They may be in a bad mood, so they're not going to, you know, they're not going to perform for you. You know, so you really have to pay attention to what the parent is saying or the caregiver. And again, when appropriate, you're going to use some standardized developmental screening tools to try to gather your information. I want to also say this is such an important part of the well-child visit because it's an opportunity for you, hopefully in most cases, to reassure the parents how well their children are doing. So, I mean, I pretty much close out every visit with, you know, your child is growing well, your child is developing, doing everything that we expect them to do at this age. And that's just something that's really important for parents to hear. Next slide. This is just to kind of remind you of the different domains of development that we emphasize during our developmental screening. So gross motor, fine motor, cognitive, linguistic, and communication skills, and then also social, emotional, and self-help. So you're going to tailor the questions that you ask, you know, keeping these domains in mind when you're asking about, you know, various things that the child is or isn't doing. And keep in mind that with language development, we're looking at both expressive and receptive language. Next slide. So this is a resource that actually was provided for me from some of the MGN staff, and I actually I wasn't familiar with it before I started researching this talk. And this is basically, it's a document that's a compendium of standardized developmental screening tools that was developed through some partner organizations within the U.S. Department of Health and Human Services in 2014. And it represents a coordinated effort to encourage the use of developmental screening, and also to provide you with a list of some standardized tools that you can use, with the idea being to both encourage the screening and then provide support for children, families, and the providers who care for them. So it basically lists a bunch of standardized screening tools that meet certain quality parameters that were set by these federal partners. And I'm providing this list to you as a resource. We are not endorsing any particular screening tool, one over the other. I think that's something that you need to decide for yourself. Next slide. And this is just to kind of give you a sense of what's in here, just in table form, some of the different screening tools that can be found in this document. Next slide. So I am going to talk about just a couple of the specific screening tools, and again, not to endorse one over the other, but just so you have a sense of what's out there. So starting with the Ages and Stages questionnaire, or the ASQ3. I personally don't use this one, but it is a very popular one that's used by pediatric practices. Initially it was mainly aimed at early childhood educators, but now it has been adopted by pediatric providers as well. And it basically provides age-appropriate questionnaires that cover all the different developmental domains ranging from 1 month to 5 years of age. The questionnaires are scored numerically. I looked these forms over, I found them fairly lengthy, and this is something that probably would work better if you decided to use it by having the parents take them home or have them ahead of time. So maybe you'd give it out at the previous visit and have them fill it out at home and then bring it in. It does cost money though. You do have to purchase this. Next slide. This is a very nice screening tool, and this is actually free. This one is used by one of our high-risk clinics at University of Kentucky. It's the Survey of Well-Being of Young Children, or the SWIC, and this comes out of Tufts Children's Hospital, which was formerly a floating hospital for children. And this form it's very comprehensive. So it also, in its questionnaires, it asks about social determinants of health, so kind of hits on some of those other health promotion themes endorsed by the AAP. It also includes the autism screening at 18, 24, and 30 months. Again, the forms are free and downloadable. It's available in multiple languages, including Spanish. So this is one that if you haven't used something, this is one that you might want to consider. Next slide. And I wanted just to mention a little bit about how you can structure your developmental screening. I think it's really personal preference whether you choose to have parents fill out forms in the office, in the waiting room, or give them ahead of time to have them fill out. I think it just depends on how you want to structure your workflow. I like to ask the questions myself. It's just what I've gotten used to over the years, and so we have our electronic record templates basically have the milestones that I can just check off as I go through the questions, and I tend to just ask the questions myself. I find it just doesn't take very much time. So again, I think you just have to think about how you want to do the screening and how you want to structure it in your workflow. And then again, some of the tools do cost money, like the ASQ3, and the one that I just mentioned, the SWIC, is free, and you can just download those forms. So lots of options that you can choose from. Bright Futures itself actually has a resource kit that you can also purchase that has the questionnaires all pre-printed. So that's another tool that you can use. Next slide. So I came across this fairly recently, and I wanted to let you know that this is out there. So the CDC actually has a website and a downloadable app. You can download it onto your phone that tracks developmental milestones. I've actually had parents in the last few years use this just on their own, basically, and then they come into the office for a well-child visit with concerns because they've got this checklist from the CDC and their child is not doing, certain things that it says they're supposed to be doing. So you definitely want to listen to those concerns. What I've found is that I often have to reassure them that there's a range of normal, and some kids do things in kind of a variety of ages. So just that the fact that they're not exhibiting a milestone at a certain age doesn't mean that they're necessarily delayed. And notice, it says this very clearly on the website when you log on, the use of this app is not a substitute for the use of validated standardized developmental screening tools as recommended by the AAP. So keep that in mind, but I think it's important to know that it's out there because parents discover it and they may use it to track their child's milestones. Next slide. So I wanted to turn briefly to autism screening, which is also very important and recommended by the AAP. So the main screening tool that most of us use is the MCHAT, which is the modified checklist for autism in toddlers. It's now revised, so it's the MCHAT revised. This is it's a fairly usable questionnaire. We actually give it out, our receptionists give it out in the waiting room at the 18-month and 2-year visit, and also if they come in for a 30-month visit. I use that as an optional visit, the 30-month for kids that I have concerns about at age 2. I'll bring them back, but the AAP does endorse this as an age to see the child for a well child visit. So basically the parent fills it out. It has 20 questions, yes/no answers basically that relate to the child's social interactions and other relevant behaviors, and you basically score it. The answer to most of the questions should be yes, and there's a few, like 3 questions that basically the parent should be answering no. So it's important to talk to families about why you're doing this screen and what you're looking for. Some of the questions on it are also a little bit confusing. If you haven't seen it before, I encourage you to you can just Google it and look at what the questions are. A couple of examples. There's a question about whether the child does repetitive finger movements in front of his or her eyes. I mean, they're looking for kind of odd stereotypical behaviors, but some parents don't understand what that means, so you have to kind of explain it. There's another question about whether or not the child is extremely sensitive to noise, and they use a vacuum cleaner as an example. Lots of kids are scared of the vacuum cleaner. It doesn't mean they're autistic, so you really you have to kind of provide a framework for what we're looking for with those questions. And also make sure that parents understand why you're screening for this and what we're looking for. You want to document your results, and there are various ways that you can do that. In our electronic record, we just have a little checkbox that says that we did the MChat and whether the child passed or not. And if they didn't pass, you need to kind of document what was wrong, and then of course you're going to go ahead and refer, or at least follow up closely. And also with this type of screening, these standardized screening tools for the MChat, there might actually be just additional charge codes that can be applied, so you might even get reimbursed by insurance for doing this screening. So something that's very important to incorporate into your well child visits at these ages. Next slide. This is also another study that I found fairly recent, from July of 2020, and this came out of a healthcare system in Utah. It was 20 primary care clinics, and they did this from 2013 to 2016, and they looked at autism screening with the MChat at well child visits in children 16 to 30 months of age. And they had an electronic record basically that reflected whether or not the MChat was done and whether the child passed or not, so similar to the way I do it at my institution. And the study looked at various things. It looked at different types of providers that were providing care for kids, so pediatricians, family physicians, or advanced practice providers. And they also looked at various demographic features of the patients and families, including socioeconomic status and ethnicity. And I think it's a busy slide, but I think one of the main thing to take away is that around 73% of the children were screened once. There's another slide that I didn't show, which shows that only 54% of the kids were screened twice. And keep in mind, they do recommend screening at 18 and 24 months at both of those visits. Next slide, please. So some other things to take away from this study. So first of all, so 1.4% of the children screened were later diagnosed with autism. So there are lots of false positives with this screening, and that's the point of the screening test. Is you want to pick up everybody, but you're going to have some false positives. So keep in mind that this is only a screen, and only a small percentage of positive screens will actually lead to an autism diagnosis. The study did also show in the second bullet point that children who did screen positive with the MChat were more likely to be diagnosed with autism and at a younger age than children that were not screened. So also important to note that why the screening is important. Screening was less likely to be done in Hispanic children, so definitely a disparity there. And finally, the screening was much less likely to be performed by family physicians than by pediatricians or APPs. So only 9% of family physicians, which frankly I found shockingly low compared to around 3/4 of the pediatric providers. So huge discrepancy there, and I think really shows that primary care providers that are outside of pediatrics really need some education about why we do the screening and how important it is. Next slide. I'm just including this as a reference, really. I'm not going to go through all of these milestones, but just to kind of give you a sense, and you can have this as a resource of what milestones we're looking for at different ages. These I pulled from Bright Futures. That's what I use in my practice, but again, there may be slight variations depending on which tool you're using. Notice that it's divided into different domains of language, social and self-help, gross motor, and fine motor. And so you want to make sure that whatever screening method that you're using, or if you're going to kind of devise your own, based on standardized tools, that you need to have questions that hit on all of these different domains, basically, when you're doing your screening. Next slide. So I want to talk a little bit at the end about early intervention, and remember that one of the main reasons that we're doing regular developmental screening at well child visits is to refer children with possible delays for early intervention services. So I want you to be aware that early intervention services are federally funded and they're mandated by law. And give you a little bit of historical background. So originally it was called the Educational for All Handicapped Children Act, which is PL 94-142. It's very famous. I remember, actually remember when it happened. I think I was in medical school. And then eventually it became the IDEA, or Individuals with Disabilities Education Act. So it's basically a federal law that mandates that all children with disabilities be provided with a free, appropriate public education. This was signed in 1975 by President Ford. Actually, I wasn't in med school, I was in college, but I remember hearing about it. And I wanted to emphasize the term at risk in the second bullet. So there doesn't necessarily have to be a developmental abnormality that's been documented. All there needs to be is a concern on the part of the caregiver to make this referral. And I want to, so it's important to know this because it means that anyone that has a concern about their child should have access to having their child evaluated by these services. It doesn't require, you can refer as a physician, but it's not required. So typically what I do is I'll, if a parent has concerns, I'll give them the contact number for our local early intervention service, and I'll go into this in a little bit, and I'll let the parent actually call and have somebody do an intake and send someone out to evaluate the child. I also wanted to, clarify what these early intervention services do. So they're to assist children with any variation in physical, cognitive, communication, adaptive, social, or emotional areas of development. And they might include various therapies, including speech, occupational, or physical therapy. For toddlers and preschool children who are identified as having delays, there will often be referral by the early intervention program to a preschool in the community that can work on various skills in a setting that will also promote social development. So very valuable. Kids do age out of these services at age 3, but then they'll get referred to their local school system once they've been plugged in. And I'll mention also there is a robust literature on the benefits of early identification of developmental delays and timely intervention. There's lots of studies that show that developmental outcomes are improved by starting these interventions early. Next slide. Couple of other things to clarify about early intervention that I think are interesting. The Individuals with Disabilities Education Act mandates that these early intervention services should be provided by qualified personnel in, quote, natural environments, so usually in the home, and they usually will send people out to the home. They're generally free, although some states may have a sliding scale. I think that varies from state to state. And they really have a family-centered approach. So they're actually going to be training, say, family members with a child that has delay, say hypotonia, to how to feed that child properly. And then they'll provide other services like speech or occupational therapy. So there are trained individuals that will actually come to the home and perform these services. Unfortunately, now a lot of it's being done over Zoom, which I don't think is as effective, due to COVID, but I think that's hopefully going to change, as we finally get control of the pandemic. Early intervention programs differ by state, and they're called different things depending on what the state is. So in Michigan, it's Early On. In Kentucky, it's First Steps. In Minnesota, it's Help Me Grow. There's a short list on this slide that actually provides links to services in specific states. These are actually the states in our Midwest Genetics Network region, but there's a link below the Child Find link that will basically identify services in any of the states. So you can basically go on this link and find out what the early intervention service is in your home state. So I would definitely encourage you to find out what the early intervention service is in your state, and have their contact information at the ready. And then you can give that information to parents. I have it on my cell phone, for the local Lexington First Steps office, and I just give them that phone number and they can call to access the services. Next slide. So we're wrapping up. This is basically from, this is a new policy statement from the American Academy of Pediatrics. It just came out a year ago in January of 2020. And this provides an algorithm for evaluation of children with developmental delays that are picked up at the well child visit. And I hit just a few strong recommendations. So at a minimum, the AAP recommends that you do developmental screening at the 9-month, 18-month, and 30-month visit. I would urge you to do developmental screening at every single one of your well child visits. I think that's one of the most important parts of our jobs as primary care providers for kids. You want to make sure that you're doing autism screening at 18 and 24 months. And again, you can also do it at 30 months if you do that visit. And then the algorithm basically goes on to recommend evaluation of the children that are identified as having developmental delays. So I'm not going to go through this in detail. It's fairly busy, but if you look on the third column, item number 8, it talks about a medical evaluation, including genetic testing, and then also looking for other chronic conditions. And basically, I'm going to use this as a segue to wrap up the talk. So this is a really good segue into our next few virtual learning presentations, where we're actually going to go on and talk about what happens at a genetics visit, and what there's a wonderful talk on dysmorphology by a geneticist in our group, and then also a talk about the specific genetic tests that are done and what we're looking for. Next slide. So I'm just going to summarize my key points today. So developmental screening is a very crucial part of the well child visit to identify delays that may be linked to a diagnosis and to refer to early intervention in a timely manner. We do encourage use somehow incorporating a valid developmental screening tool into your visits to assess development at each visit. You want to make sure you're listening carefully to and addressing concerns that caregivers express about their child's development. And then finally, familiarize yourself with early intervention services in your state. And that's a wrap.
Thank you so much, Dr. Behar. That was a wonderful presentation. I would like to take this opportunity now to field any questions, either for Dr. Behar or for the team at MGN. As I mentioned, there are several of us on the call today, so happy to hear your questions. You are welcome to put them in the chat if you find that easier, but you are also welcome to unmute yourself and ask your question. If we get lots of questions, maybe we'll use the hand raise function, but feel free to either chat in or unmute and ask your questions.
This is Dilli Ramesh. Yeah.
Yes, go ahead.
Hi, see you.
I like your presentation, and we do MCHAT for 9 months, 18 months, 18 months and 24 months. The question I had is, what's your visit time like? We do have 20 minutes. Sometimes it goes beyond that.
Yeah.
So, because we can't have 30 minutes, then it becomes an issue.
Right.
With the
Yeah, and I think every practice is different. It's funny, when I was in private practice, we actually had a 15-minute slot for well child checks under the age of 2. The practice that I'm in now at the university, they allow 30 minutes, although some of that time is taken up by vital signs and that sort of thing. But I think it takes less time than you might think, basically. Obviously every visit's different and you don't know what concerns are going to be raised, but I think, I think we're talking about under 5 minutes, basically, to ask, to pick questions from each of those developmental domains, and ask them. And again, with the MCHAT, I have the parent fill it out ahead of time, so I've got it, basically in my hand. Occasionally the nurses forget to do it and then I have to go through it myself, but that hardly ever happens. We've got our staff really well trained. So, so I can look at it and, honestly, for the majority of kids, you look for your 3 no's, down the line and you may have to explain a couple of the questions, as I said. It really doesn't take as much time as you might think. So I find for myself, I can get it done in the context of a 20-minute visit without too much trouble. It takes some practice and but once you get into a flow, I think it's definitely doable. I don't think it adds that much time to your visit. And again, it's so important. It takes for an infant, it takes 2 minutes to examine a baby. So yeah.
One more question. Do you get any feedback from early on? Because we send our early on Michigan, we give them the paper, then 3 months later, the mother comes, I called, I didn't get any response. So
it's a great question. And I did practice in Michigan, for many years before I came to Kentucky, but pretty much the same in both states. No, you don't get a lot of feedback. What I usually do, sometimes I'll get a request for medical records, which, but that not even that often. So I just end up asking, at the next, because you're going to see them back in, whatever, 2 to 3 months or 6 months. I end up asking, did you make contact? What are you doing? And, just so I can get a verbal description and document what's happening with the family. But no, I don't get written communication. Yeah.
So I see several questions have come in on the chat, and Danielle, I'll let you read those off as we go through. We probably are going to run out of time. If we don't end up getting to all of the questions, we can answer them and make sure we get answers out to you guys through email. So go ahead, Danielle.
Yep, we can put something out in the resources tab when we post the recorded video. The first question, Mimi, that we have is, why do we think that there is decreased testing of Spanish-speaking patients, and how do we fix that problem?
Yeah, that's a really good question. I was surprised. I was surprised to hear that, and we actually have a fairly. So again, this study came out of Utah. We've got a fairly big Latino population in Lexington, which is where I am, and we have we actually have on-site interpreters, that we use in our clinics. So we're pretty well set up, and it may have to do with the way they're set up and they didn't go into specifics about what the reasons for it was, but it's clearly a disparity and clearly something to work on. you have ready access to interpreter services now on your phone. So if I don't have access to an on-site interpreter, I can just call up, I can call up a interpreter service basically and have somebody that I can use on speakerphone. That's going to add to the time that you're spending. So, so if you're a provider and you're not a native Spanish speaker and you're relying on interpreters, it's going to add time to your visit. So I suspect that might be part of the issue in some of those clinics that they were looking at in Utah. So you might have to change your template, to add an extra 10 minutes maybe to your visit, if it's a Latino family, so you can get the screening done. I think there probably are some solutions, but it's just a guess as why that might be different. I suspect language has something to do with it.
Thank you, Mimi. Yeah, we have a few other questions. Matt, we are right at time. Do you want me to do them, or should we kind of wrap up?
I think let's go ahead and wrap up. I don't want to be disrespectful of people's time, but we will answer. I see there's at least 2 or 3 more in there. We'll make sure we get those answered and get answers out to the whole group so that you can have those. Thank you everybody for getting on today and participating, and we're looking forward to seeing you all again in about a month or 3 weeks to a month for the next presentation. So thank you everybody.